we are going to move to our keynote speaker. And here to introduce her is Henry Bailey, who is my former contract student. He is a 2L and president of the Black Law Student Association. And he will introduce our keynote speaker. Thank you.
Good morning. Again, my name is Henry Bailey, and I have the pleasure of introducing Cheryl A. Boyce to you this morning. She is the executive director of the Ohio Commission on Minority Health, a native of East St. Louis, Illinois. Her interest in public health was a result of the premature death of her father. The commission focuses on improving the health status of African American, Latino, Hispanic, Asian, and Native American Indians. She earned a Bachelor of Science degree in Health Education from Southern Illinois University at Carbondale and a Master of Science in Health Planning and Administration from the University of Cincinnati. Ms. Boyce has held a number of progressively responsible positions in the human services field, including coordinator of the Governor's Task Force on Black and Minority Health, Ohio, program director and associate program director for Advocacy and Protective Services Incorporated, and was employed by the Ohio Departments of Health, Mental Retardation, and Rehabilitation Services Commission. She has been acknowledged for her work as the recipient of numerous awards, including the YWCA Women of Achievement Award for Racial Justice, the 1999 Columbus Urban League Award of Excellence, the ONI Award presented by the International Black Women's Congress, and the National Black Programming Consortium Health Award. She's an adjunct professor at Franklin University in the Health Services Administration program. And with that, I bring to you Ms. Cheryl A. Boyce.
Thank you, Henry. I am so impressed with this young man. We're going to be hearing great things about him. He has a vision and a path all laid out, so thank you very much for the introduction. And I want to thank Professor Yearby for inviting me. I'm absolutely delighted to be here as we face another Minority Health Month with great enthusiasm in the state of Ohio. I need to make one correction. I am not the executive director of the Ohio Commission on Minority Health. I had the honor of serving in that capacity for almost 3 decades. So you want to make note the executive director of the Ohio Commission on Minority Health is Angela Cornelius Dawson at 614-466-4000. If you need anything at all, you call Director Dawson. I retired in 2010, and like I said, it is such a blessing to do work that is your passion. When I talked to Professor Yearby, I could tell that this was her passion. And so I was going to do the PowerPoints, and I looked at the presenters that were coming, and you had an extraordinary cast of characters to present. Nationally recognized people who have done this work for a long time. And so I decided, they had asked me to talk about the commission, so I'm going to tell the Ohio story, and hopefully most of you are aware of it because many of you have been along on the journey. And as you leave this place, I know that the information you've received is not going to be stagnant, that you're going to move it forward, and it helps to be able to build on the history of that which has been accomplished and to have a clear vision articulated for that which is to come. And so I would be remiss if I did not acknowledge the chairman of the Ohio Commission on Minority Health, Dr. Greg Hall, who you met earlier, who has worked tirelessly in this community. So I got 20 minutes, so I'm going to stop in 20 minutes. But you very seldom find practitioners who also deal with issues of policy and who do community service and on and on and on. And it is what I believe, in my heart of hearts, we're all called to do. Nobody in my mind can just do what it is you do professionally if you don't translate it into making life better for other people. So I don't care if you're a researcher. Who cares about research if it doesn't articulate and translate into better lives for people in the community? Who cares about the law if it doesn't improve the life of the community? And so I think I'm in the right place as I listen to people talk and who are bringing their expertise to the table. And I also would be remiss if I did not acknowledge Johnnie Chip Allen, who I met years ago when he was a very young spry thing in Cleveland, Ohio, working in the community in HIV and AIDS, and he is the Health Equity Director for the state of Ohio and a designee to the board of the Ohio Commission on Minority Health. And I also need to acknowledge my husband of almost 40 years, Russell, who is with me every place I go, and I certainly could not do this work without the sacrifices he makes. And our aunt and Uncle Lois and Uncle Chet, thank you for coming. The Ohio story started a long time ago in the mind's eye of lots of people who cared about the community and who were watching the disparities. For some people, the disparity is simply an anecdotal statement of fact, of statistics. But for many of us, we're watching our neighbors, our friends, and our families die prematurely from preventable diseases and conditions. And so it becomes something else for us. And so Archie Lewis, who then worked at the State Health Department, back in 1982 or so, Dr. Hall showed you the report of the Margaret Heckler, the Secretary's Task Force on Black and Minority Health report. As they were doing their work, nobody was paying any attention to them, but Archie Lewis was. And she brought them to Ohio, and there were 2 conferences put on, very nondescript names, the GAP 1 and GAP 2 conferences. And the people who were on the Secretary's Task Force came to Ohio and orally disseminated the findings that were coming from the Secretary's work. About the same time, Ray Miller, who you met yesterday, who conceptualized the legislation for the Governor's Task Force on Minority Health, which was the forerunner of the task of the commission, had gone to Rensselaerville, New York, and someone was giving a speech talking about the premature loss of life in the community and that survival outcomes were improving for people, but they kind of incidentally said, unless you happen to be a person of color. He believed that if there was a disparity in health status nationally, that Ohio probably was faring no better. Came back and, as Dr. Hall said, convinced Governor Celeste to create the Governor's Task Force on Black and Minority Health. And so I need to talk about, my mama on Sundays used to always cook the cheapest cut of roast beef she could find because that's all she could afford to cook. And I don't care how much we ate that sucker, she could always find enough meat on Monday to make hash. She could always make something out of nothing, and that's exactly what happened. So the resiliency of the community served us well with the task force. We had $90,000 to staff, 12 months to figure out if there was a disparity in Ohio, why there was a disparity in Ohio, and what we could do to ameliorate it. So we met people like Terry Allen and went around and talked to people, and there was not a lot of literature on the health status of people in Ohio. So we decided the one place that we could go to figure out what was going on was the community. So we went out, we identified indigenous leaders throughout Ohio and asked them if they would help us access communities for people to tell us their story. And I need to tell you, we were focused on treatment, but the community was smarter than we were. They said, if you're so smart you can treat disease, why can't you help us prevent disease? And I thought, that's a novel concept. And, it amazes me that we act like the community standards are so much lower and they don't know. The answers are out there in the community, we just need to ask. And I was shocked. We came to Cleveland. There was so much testimony in Cleveland. We were here for 2 days. We were fortunate. State legislators came, legal people came, and somewhere around that time, I was at a meeting in Baltimore, Maryland, and there was a woman at the microphone, and she was speaking so eloquently about the problems that communities were experiencing. And afterwards, I was so excited, I went up to her and I said, oh, I was so impressed with you and your vision of what's happening in the community. We need someone like you in Ohio. And she said, I'm from Ohio. And it was Dr. Randall. And so she joined the merry wagon of people doing work back then. And that's what we've done. We have tried to identify people. There was a comment made in the last session about grassroots efforts. If we wait for the people at the top of the food chain to solve these problems, they're never going to get solved. We need to go to the community and find people who can articulate their own vision and support them in doing that. We shouldn't be speaking for them or any of those things. Over 2,000 people came out and testified at the public hearings about the atrocities they had experienced at the hands of the healthcare system. We learned a lot, but we also took with us the health commissioner for each area, the state legislator, and for each area from the House and the Senate. We took policymakers with us that we believe needed to hear from the community what could be done to make a change. At the end of all of this, we had promised the community that if there was ever any action taken as a result of them sharing their experiences, that we would enter into a partnership with them. The commission has been in existence almost 3 decades. The commission has honored that commitment to be in partnership with the communities, and in my estimation, it's one of the strengths that the commission had and continues to have, is honoring that commitment. We came back and the community thought, we need somebody focused on this issue 24/7. We want a freestanding state agency established. And I thought, that's never gonna happen, not in my lifetime. So I need to tell you that the perspective I'm sharing with you is from the minority health movement perspective. And that's certainly not to say that we were the only people working on this issue, but it's the place at the table that I sat, and it's the story that I know the best. And so that's the story I'm sharing. Doesn't mean that there were not other casts of characters from other state departments, community-based entities and organizations. So we issued our report and our findings in 1986. And lo and behold, because the community sent slivers of pie with notes attached to it and everything else, in July of 1987, the Ohio Commission on Minority Health became the first state agency in the United States exclusively devoted to issues of eliminating health disparities. The commission, because of the community's efforts, the commission has a line item in the state budget. It is not only a freestanding state agency, it's a freestanding state agency with a line in the state budget. That's a biggie when you consider that there was no infrastructure or anything on which to build, and it was on the backs of the community that this effort went forward. So the commission started off providing grant funds. You've all talked about the disparities over these 2 days. Heart disease, certain cancers, type 2 diabetes, infant mortality, substance abuse, and violence were the 6 diseases and conditions responsible for 80% of excess deaths in the community. HIV and AIDS had not raised its ugly head at the point that we started our work. And so our feeling was that there were things the system did right. And so I really love the fact that this session was framed in individual, institutional, and systemic change. Because the fact is, everybody wants to talk about what people in the community need to do to change their behavior. I want to know where the people are talking about what the system needs to do to change its behavior. Because part of the reason the disparities exist is because we have poor public health policy. We have legislation and laws that don't meet and address the needs of the community. So there's a whole enough to do on that side as well. We felt that if we provided grant funds, we were so Pollyanna back then, we thought that providing grant funds for people to do different kind of programming would show the system that there were other ways to make significant changes in the health status of these communities. And we were not looking at all the other things that the commission now looks at and tries to become involved in. We gave out grants, and even though we knew that they worked, we had to convince other people. So the grants, it didn't take us long to figure that we needed to go upstream. The grants were 2-year grants. They were up to $400,000 per agency. Who have you seen give a community-based organization, a real community-based organization, $400,000? But the community rose to the challenge. How many of you know what April is? Do you know where Minority Health Month was founded? In Ohio, and became a national celebration in 2000. In 1989, there was an attempt to simply do community-based programming so that everybody, it's really important, whatever you choose to do from this point forward, it's really important for you to believe and to convince people that everybody has a seat at the table. There is a role for everybody. Joe the wino in your community has a role in solving this problem. It is a problem we all need to be resolving. So this is a sample of the calendar. The first year there were 87 events all over the state of Ohio. This is a sample of one of the calendar of events for Minority Health Month. All of these events are planned and executed by community-based organizations. You will find calendars like this in at least 46 states and the territories. So there are now 46 state offices of minority health. There are offices on Guam, Micronesia, and Puerto Rico. And so the commission decided then, if the community could do the services, what could we do to start trying to look at some of the systemic changes? You will note that in Cleveland, there is an Office of Minority Health, and I believe the director of the Office of Minority Health for the city of Cleveland is here. Can you stand up? We want everybody to see you. So you take all your Cleveland problems right here. So thank you for being here. The commission moved from looking at services exclusively to looking at capacity building and infrastructure development. It is impossible to make a change in this work by simply throwing out dribs and drabs of grants and expecting community-based organizations to do something with the little when everybody in the system has a lot and can't do anything. It's the difference between having a plant with no root system and having a potted plant with a root system, some fertilizer and water. And so we really need to be doing infrastructure building and capacity development. So the commission established offices of minority health in 6 of Ohio's largest cities. So every major city in the state has an office of minority health as a local point of contact. We also created at the commission, which still continues, a program called REAP, the Research Evaluation Enhancement Project, where every project is evaluated and there are metrics in terms of outcome for the institutionalization of those services. So it's not anecdotal that these methods the community is using works. There are researchers and evaluators all over the state that are going out and doing the measurement for them. So it wasn't good enough then to have infrastructure at the state level and the local level. CHIP is involved with the directors of health education, and I don't have any problem. I love systems and systems change. I don't have any problem with ripping off stuff that looks good. And I noticed that they had kind of institutionalized some of their stuff that we weren't able to institutionalize. And one of the reasons we hadn't been able to do it is because when Ohio established its commission, it did it based on the needs of the people. As each state started an office of minority health or commission, they did it based on their needs. And so when you put us all in the room together, it's kind of like being in here. It's like the Tower of Babel. Everybody has their own dialogue, they have their own jargon, and we may be talking about the same thing and not using the same words, and you cannot harness the synergy of this work unless you're all on the same page. So in 2005, in deference to the work of the people of Ohio, there was established the National Association of State Offices of Minority Health. We identified 10 core competencies you should find in any entity that provides minority health services. And so that national association is working to create infrastructure nationally to do this work. While there are things that I like and don't like about the Affordable Care Act, I will say that anytime you don't do change, you're stagnant. And so it's change, it's still got its flaws. But in the Affordable Care Act is the codification of offices of minority health in every major branch of the federal government. There are standards created for community health workers, because my experience in public health has been anytime the budgets go south, the first people they fire are the community folks that are doing community work, and everybody decides what they want people to do. But the Department of Labor has recognized community health workers as a viable entity, and it's a group of women predominantly that we really should use who are indigenous to these communities. There is the National Partnership for Action to Eliminate Health Disparities, and there are people from throughout the state who are on the health equity councils that are regional councils that have input on policy. I'm saying to you that there are lots of opportunities to connect and to do this work. So I think I have 5 minutes left. I have one recommendation, and some people have talked about things that I think we could all agree on. And Chip and I have had, and Vernellia have had long conversations about health disparities, health equity. We may want to talk different languages, but I bet there's nobody in this room that if you said, do we want to create equity for everybody? Yes. Do we want to eliminate health disparities? Yes. So why are we having a discussion? It's kind of like we may see the outcomes that we want being the same. We may see different ways of getting there. But what other group of people only do stuff in one way? There's room at the table for everybody to bring their solutions. When you leave this place, I would hope that there is some concordance that we should create a statewide group of people representing a multidisciplinary approach that can sit at the table and come together and agree on the direction that we're going to go. And whether it's the Office of Equity at the State Health Department or the Commission on Minority Health or the Health Disparities Collaborative or any of the other groups that exist, that we basically form an infrastructure to support, sustain, and maintain this work. You can't do it by yourself. We can't do it by ourselves, and neither can anybody else. The fact is the workforce problems are all of our problems. The last time I looked, if you looked at every medical school in the United States, fewer than 2% of the people teaching in them represented underrepresented minorities. How do you get to the point of seeing things in different worldviews if everybody is myopic? You can't do it. And so the workforce problem is a problem for all of us. The resourcing of these communities to do the work is a problem for all of us. And I could go on with the whole litany of problems, including my personal favorite, licensure, which I think is a way of closing people out of servicing the communities they come from and bringing in people that don't understand the context of those communities to try to translate health information to improve health status. Intuitively, it makes absolutely no sense. So I applaud Professor Yearby for bringing you together. I celebrate the fact that you've had the advantage of expertise. Ohio's story is one of many stories of people trying to do something in this country. But the fact is the uphill battle that we're facing in creating the infrastructure, no other professional group has had to overcome it. CDC has provided funding to seed every other group of people who have tried to do what we've done. We've existed 30 years. They've not invested one dime. This work has been supported based on the commitment and the dedication of people all over this state and all over this nation. The disparity at some point is going to go away. The reason it's going to go away is because health status is getting so bad for everybody. We're going to all be disparate, and it's going to be the norm. So I would hope as you spend your last time discussing today what you're going to do, that you would kind of think of what's going on. And I've been outraged every time I look at the TV and they talk about we've got to do something because cocaine is taking a foothold in the community. Well, cocaine has been taking a foothold in the community for a long time. It's like, whose community are we talking about? And so all this stuff, if we don't get a handle on it, health problems permeate up. I mean, it doesn't take a rocket scientist to figure out if we don't stop it, it's just going to continue to impact more and more people. I will leave you with the way I leave every presentation, and it really is, for me, the formula as to how you make things work. So as you use your litmus test today, I hope that you will take into consideration. Go in search of your people, love them, learn from them, play with them, and serve them. Begin with what they have and build on what they know. But of the best leaders, when the work is done and the task is accomplished, the people will all remark, we've done it ourselves. Best wishes to you as you labor on this really difficult, time-intensive subject. Thank you for having me.
So we want to open it for questions. Are there questions? Yes, hold on 1 second. Let's get you a mic.
Wonderful presentation, thank you. You mentioned you had.
Hold on a second, I don't know if it's on. Is it on?
Hello, it's on? Okay.
Can you tell us who you are?
Sure, my name is Chesley Cheatham, and I work at Seidman Cancer Center, University Hospitals. I'm new to Cleveland, so all of this is wonderful being presented. But just a quick question. Could you expand a little bit about, you said you had a pet peeve against licensure. Could you tell us what that means and specifically in?
Okay. I had breakfast this morning at 7 o'clock with people who live in Cleveland who are part of NOBADAN, the National Organization of Blacks in Dietetics and Nutrition. With the obesity problem, we would all recognize that we're not going to overcome, especially the translation of stuff, unless people understand how people prepare food, what taste, because if it doesn't taste good, why would you continue to eat it? So I've been places where people cook black-eyed peas and put them in a pot for 10 minutes with just the water and boil them for 10 minutes and put them in a little cup and pass them around. Who's gonna eat that? Nobody. And so if we don't understand the context of food, how do you help people do a translation of it into healthier foods? When I started my career in a federally qualified community health center, and back then there were lots of community health workers. They were called just outreach workers in those days. There was a woman there who had a PhD in dietitian. She was a dietitian. But she had no idea what people were eating, how they were preparing, or anything else. But the women in the community who had been taught and went out to people's homes, people would come to the clinic to see them without a doctor's appointment. And so they were, as far as I was concerned, they demonstrated the efficacy of what they were doing. The state decided that we needed to license everybody that does dietetics. And in Ohio, we have the same problem at this point. I believe that a lot of professions are doing licensure to self-protect in their professions, and it has nothing to do with providing better services in the community. So all the expertise that was brought from those women, regardless of which group they represented, to this, if you look now, and And again, if you look at almost any medical, allied health profession, you find almost no underrepresented minorities in those professions. They're locked in the balls of them as aides and techs and everything else. So my other pet peeve is once we decided we were going to license them out of existence, we did not set up an articulation pathway for them. So that if somebody is I don't have a problem, if somebody is a diet tech and they want to be a diet tech, power to them, I have no problem with it. But if they want to be a dietitian, there should be some way to articulate them up through that profession and not just lock them in the bottom. Because as long as we do that, we're going to always need people doing interpreting and everything else. If we open the pathways of these professions, we would not need all the ancillary people because we'd have people that were trained in the professions.
All right, let's come over here.
Good afternoon. My name's Tom Cromer. I'm an attorney, a CPA, and a certified financial planner. I'm married to a physician. I went to law school here at Case Western Reserve. I came back up here to visit some people, and I thought, hey, I might as well get some continuing legal education while I'm here. And your course fell on this day. I was not expecting this. To use your words, Mrs. Boyce, I'm a minority in this group as I look around. I'm at the top of the food chain, okay? And you made a comment that the top of the food chain won't help. When I stumbled into this program, and when it got going, I wanted to leave. I didn't feel comfortable in here. It didn't make me feel good. I was the problem, and so is my wife. And I disagree with that. I stayed here. I forced myself to stay here because when a problem needs to be solved, there's usually two sides to it. I could have walked out of here and said, they don't know what they're talking about. These are a bunch of takers. I'm a maker, and I'm fed up with it. I didn't do that. He taught me here at Case Western, if you're going to solve a problem, you have to listen to both sides of it. I stayed here and I listened. I need to know how the other side thinks, what they want, and how they're going to get there. I want the problem solved too. It's not good for our country or the world to have half of the people here pay no income taxes and getting a lot of support and subsistence from the federal government and every other program. We cannot do that. I'm an accountant, tax guy. We're $17 trillion in debt. That's $45,000 for every person in this room. Raise your hand, who can write your check? Come on.
Sir, could you turn the phone, give the microphone? We don't need you to lecture us.
I'm not lecturing you.
Please give the microphone.
I'm giving.
Ask her a question or give the microphone back.
I'm giving you a gift.
No, you're not. I'm older than you. I know
We-
you ain't giving me a gift. Give the microphone back. You're exercising your male and white privilege to come into a room that is addressing a problem that is real to the people in the room, and then you're gonna lecture people on your white and male privilege. Ask her a question or give the phone back.
I won't solve the problem unless you see the other side. I paid for this seminar. I've listened to 9 hours of it. Can you give me 2 or 3 minutes?
You've already exercised 2 or 3 minutes. Would you please ask her a question or give the microphone back?
I want to solve the problem and work with you to solve the problem. I want to bring both sides to the table. You're looking for a consortium and people that are interested. I have no desire to keep the inequities in place. I want everybody to rise to the level where they're educated, where they have a job, and when they're healthy, because that's good for all of us. I want to do away with that inequity. What scares me is that the other way to do away with the inequity is when everybody is poor, uneducated, and unhealthy. We have a problem with funding. We have a problem that needs to be fixed. Everybody has to be at the table. I'm on the other side. I stayed here. I want to help. I don't want to be thrown out, and I don't want to be shut down. because I am a white male and a minority in this discussion. Thank you.
What I would say to you is I would like your name and phone number, and I will be in touch with you. Every time I listen to, and I'm just speaking for me, when we started this 30 years ago, every time I listen to somebody, whether I agree with them or not, I learn something, and it moves the agenda. And I didn't say that people at the top of the food chain couldn't solve the problem. They haven't solved the problem, and often will omit people from the bottom of the chain. But I think that there's stuff to be learned from both angles, because like I said, part of this is the behavior of the community, but the other part of this is the behavior of the system. And once we're both at the table, and I can see your opinion, and you can see the fact that there are systemic barriers that have contributed, I mean, substantially contributed, it gives us at least some common ground to start working at. I would love to have your name and number.
You will receive it.
Thank you.
Thank you.
All right, at this time, we are going to do a book signing really quickly down here at the front. Professor Randall is going to sign her book, and you can purchase it for $20. And then we are going to begin our next session. And so I would ask that the people who are on the last panel can come down.